There's currently a trial, which we've just started, where we are doing upfront treatment with resection plus GammaTile, letting that work for several weeks, 4 weeks, and then afterwards supplementing with a lower dose of radiation and chemotherapy. And the hope is that could this move the needle in these patients with these horrible tumors, which hasn't been changed at all for decades. And so the hope is that by doing this implantation up front, these patients are actually going to have a much better quality of life, live longer, and have a much longer progression-free survival for these tumors.
Brain tumors are a very scary thing, and rightfully so, because that's a very intimate structure that's extremely important. Today, I talked with Dr. Jay McCracken of Piedmont Hospital, who is a neurosurgeon specifically for cancer, so basically neurosurgery in oncology. And we talk about all kinds of things. Meningiomas, are they cancer or are they not cancer? Glioblastomas, one of the most dreaded diagnoses in the cancer world. Radiation, surgery, and how we can have more precise radiation delivery and quicker delivery to hopefully reduce long-term side effects when we're able to control disease for a long time. Dr. McCracken, we're super excited to have you.
Thank you. I'm so happy to be here.
Tell me, what made you, if I may, for a second, because obviously neurosurgery is super grueling, what made you decide to go into neurosurgery?
Well, I really liked the anatomy of it all. I liked the challenge. I just liked the way that the brain and the spine functioned, and I liked how much more complex it was than any other system of the body. So to me, it was a combination of all those things while still being able to use my hands to help actually fix people as well.
Is neurosurgery residency as terrible as everyone says it is? I mean, even as nerdy medical, not cool surgeon people, just, it just seems grueling.
Well, it's 7 years, base 7 years, usually a year or two of research built into that. The first couple of years are really the most challenging, a lot of hard work as young residents. As we get older in the training, you get to do quite a bit more. And then once you finish, you move on to fellowship, which can either be 1 to 2 years. So in all, it could be anywhere from 7 to 9 years of training after medical school. So it's tough, but I think if you love it, it's worth it.
So the cool thing is you focus on not just neurosurgery, but neurosurgery in an oncologic space, meaning cancer-related stuff. And I have to ask, though, what made you decide on cancer specifically? Because there's so many things about the brain and spinal cord, and if people don't know, it's how I learned it when I was, and still am treating cancer patients as a sanctuary. It's kind of almost a space that's different than the systemic space. We have drugs that work well in cancer that can't penetrate, can't even get in there. It's actually, even though it's in there, it's not in there. So that makes it really unique. And the second thing that makes it very just different than everything else is that those cells, to some degree, don't just regenerate like everything else does. You get a cut, you end up seeing the cut go away, right? You end up having, colon stuff that gets, out and removed. But in the brain and spinal cord, hence all this stuff about stem cells and how do we get, deficits from stroke back, it's so intimate and just almost in some way more divine, right, than the rest of the body.
And I think that's part of the reasons why, I went into, neurosurgical oncology, is that there's so many things that we can and can't do, and we are still limited by the functional processes of the brain, right? I mean, there are still so many eloquent parts of the brain that we can and cannot go into. One of the things that I really loved about it is because the challenge of removing a tumor from somebody's brain, but being able to work around those eloquent areas to preserve language function, to preserve arm and leg function is amazing. And so we use a lot of techniques that allow us to do that. And so, our sort of motto is maximal safe resection and functional preservation. And so we always have to balance how much of a tumor we can remove by still preserving function in the patient. And so we use things like awake craniotomy to preserve language, motor mapping, subcortical motor mapping, all these things that we can identify tracts of the brain or areas of the brain that we cannot physically see to know how to keep people safe during surgery.
So those tracts, you mean basically kind of making sure they're awake while they're being operated on so that they can continue to demonstrate their speech ability and their motor ability? Just because we know the anatomy really well, but it's a different thing, in every person, especially when you're in there, you're making sure instead of waking up in anesthesia and not being able to talk, that they're still able to, have those functions during the surgery?
Yeah, one of the coolest things we do is an awake craniotomy, where after we have initially put the patient to sleep, so we can do the initial opening, open the skin, open the bone, expose the brain, we will actually wake patients up, and then we go through a battery of language tests with them. So ask them to count, ask them to repeat sentences, ask them to complete sentences, All the while, we are stimulating the surface of the brain to see if we can get disruptions in those language functions to identify where they're located on the surface of the brain. And we know if we do, we can't go there. We have to stop. And so it allows us to do some really cool surgery and remove a lot of tumor up to basically the breaking point of where we can't anymore.
And you do that by like putting like a needle or a little thing in that area and just seeing if it's a problem, or?
So we actually have what's called a Ogemon stimulator. It's a bipolar stimulator which emits a small current between the two probes. And as we put that on the brain, it delivers a small electrical current. And what happens is it breaks those pathways temporarily. So if we're asking a patient to repeat back to us a sentence or count backwards, as soon as we stimulate that part of the brain and it breaks that language connection, you'll actually see speech arrest. So the patient will actually stop. And so we know that that's a part of the brain that we can't go into.
And then you can obviously just shut that little transmitter off and then be like, well, we can't go there.
We just pull it off the brain, and then typically they're able to resume those functions again.
I cannot imagine how disorienting that would be for someone that's like, I mean, that's anyone that has a stroke, unfortunately, experiences that. It's just wanting to say something. And, you know, it's unfortunate with stroke patients and cancer patients, a lot of their personality changes either because of like just immense frustration that an adult just cannot conceive about being able to do something that you've done this whole time, and the almost out of body experience of like of that same command. I mean, I get anxious thinking about it. They go through that every day, right? And then the other one being really a personality change due to a place, just like the motor and language stuff that can be kind of impaired when you put these frequencies. I guess, I don't know if people don't believe it or what, but the same exact thing does happen with like disinhibition and anger and control. Like those are very organic things that I think are kind of, you know, under talked about, if that's a term.
Yeah, and I mean, and that's how we a lot of times find that patients have a tumor, right? They've come in and they've noticed progressive change in their personality, or now they're more angry when they used to be so happy-go-lucky, or they've had progressive weakness of their arm or leg, or they're dragging their foot, or they've had subtle speech, issues, which they haven't really chalked up to being much of anything, but then over time they've noticed that it's getting worse and worse, and so they come in and we find tumors on the brain because of those issues.
Now, I have to ask this before we go further, because I heard this a long time ago, and I've just never, basically reconsidered it since early in medical school. And I heard, and I hope no one freaks out if they hear this, is that if there is a brain tumor related kind of headache, that it's like one that's like right on the top and not the ones that are behind the eyeballs or the temples. And of course, it's positional, but is there like, nobody complains that like it hurts like right here. Is that a thing? Is that literature supported?
Yeah, I mean, I will tell you that in general, most headaches, and everybody should not worry about it, the vast majority of headaches are not related to brain tumors. And so, your first thought should not be, my gosh, I have got a brain tumor, I need to rush off to the ER, because that's usually not the case. Headaches are so multifactorial that, in the vast majority, migraines, tension headaches, too much computer time, too much caffeine, too little caffeine, no hydration. There's so many things which cause headaches. Thankfully, the brain does not have pain receptors. And so typically we don't have focal headaches because of a brain tumor. That's the same mechanism which allows us to do an awake craniotomy. That's why we can wake somebody up at the time of surgery, remove part of the brain without them feeling it, because the brain has no way to feel pain. Okay? So when people do have headaches, typically it's from pressure in the brain. So if a tumor can get so large and it's taking up pressure, it's putting pressure on all the normal structures, causing a lot of swelling, we can get a global headache because of that. But in general, we typically don't get pain here or here in a certain place because of brain tumor.
We know that obviously by far the vast majority of headaches are not, cancer related and stuff. But when you get into trouble or you have a brain tumor, you mentioned swelling, and we know that the swelling process is challenging because unlike if you bruise your arm or if you bruise anywhere else in the body, it grows, right? It's like, oh, it's swollen. We don't realize what a luxury and a blessing that it is swollen is. Like the fact that it's swollen is actually a blessing. Can't swell in here, right? It's a totally closed space. And unfortunately, if you've ever heard of primitive brain and midbrain stuff, what that means is that's kind of the stuff that's the closest to getting out of this, if I understand it correctly, the cranium. So if you get swelling, even from a stroke or a bleed, especially externally, like we're talking about like bleeding stuff and things, that's when you get into trouble because of this herniation concept. But that's different than the kind of swelling that you get if it's like a tumor related. We know tumors in general just recruit a bunch of stuff, inflammation, and they just recruit a bunch of, almost like if you're seeing something on the street on a YouTube video and you see all these kind of onlookers, that's what the immune system does. It comes on and kind of circulates around, and that can be problematic, right? And that's why we treat with steroids, because sometimes, and you know better than me, but a lot of times the swelling and quote unquote edema, the same concept of having swelling in your calves, when you push, you can kind of see a little indentation. That oftentimes has worse symptoms than the actual tumor itself.
So swelling is usually a consequence of irritation of the brain, and whether it's physical pressure or whether it is, actual inflammation or invasion of the tumor into the brain, that all cause irritations and edema or vasogenic edema of the brain. Oftentimes, symptoms can be just as bad from the edema as it can the actual tumor itself. And you're right, oftentimes we use steroids as a bridge to get to some form of treatment. So in general, steroids are not a long-term treatment. They can come with their own host of issues long-term, but we use them as a bridge to sort of help symptoms until we can actually get them to surgery, radiation, chemotherapy, whatever it may be.
When it is cancer-related, the first thing I'm going to ask is meningioma. The biggest question that I think a lot of people have, even if they're medical, is, now we're talking about, first we'll talk about primary brain tumors, which means it originated there. It ain't from something else. It's just where it came from. Like that tissue that was at once in the brain and doing what it's supposed to, or in the head, all of a sudden goes rogue and gets, some mutations or whatever else to be able to grow in a place that it shouldn't be. The most common question I get in my quote-unquote DMs and stuff is like, is a meningioma cancerous? And I'm sure you get that all the time.
Thankfully, the vast majority of meningiomas are benign or non-cancerous. 80 to 85% of meningiomas are benign. There's a smaller subset, which we call atypical, about 10%, which can act more aggressive. Some don't, but can act more aggressive, have a higher ability to come back even if they're removed. And then there's a very small subset, about 5%, which are malignant, which do act like a cancer. Though they don't spread to other parts of the brain, or the body, they can just become locally recurrent. But the vast majority that we see are meningiomas. They're actually benign. They're very common. About 1 in 10 women, about 1 in 20 men develop them in their lifetime. Most are small. They grow over years, not
One
weeks.
in how many?
1 in 10 women, 1 in 20 men.
Get a meningioma?
Yeah.
I did not know it was that high.
Yeah. So it's actually a very high incidence, but the vast majority are small and the vast majority are asymptomatic. We see a ton of patients who come in that have a headache and they had an MRI which shows an incidental finding of a meningioma. So the vast majority don't need any treatment, and the vast majority we just watch with surveillance imaging over time. Where you typically get symptoms is when these meningiomas push on parts of the brain which cause symptoms. They're pushing on the language area and somebody's developing speech issues. They're pushing on the optic nerve and they start having blurred or double vision. They're pushing on a cranial nerve and all of a sudden they start getting facial pain or difficulty swallowing.
In the same way, like interrupting, like with your little radio tracer fancy device thing to stop the brainwaves. It's like that. It's literally just saying like, hey, you're not able to communicate, and therefore now we need to like alleviate or take off the pressure off of that thing so it can continue its track.
That's right. So the reason why we intervene on meningiomas for the most part is either they're growing over time on an MRI, or they're causing symptoms based on what part of the brain they're pushing on.
So that brings us to the conversation of intervening or intervention. I don't even know if intervening is a word, but that's the key, is when you have to take out something. From what we already established is obviously an extremely intimate area because you just don't really grow it back, and it's just so key in the rest of your life and how it functions, and it's been developing forever, and then it just freezes and stops developing, unfortunately, which is why people don't usually recover from spinal cord injuries and strokes, etc. We want to be very careful to take out just what we need to reconstitute, whatever the process was, if it was benign, and obviously take out as much as we can if it's quote-unquote malignant, meaning cancerous, meaning it's going to continue to grow without its removal. So the foundational mainstay, at the very beginning at least, was obviously just like take out. Whatever you can resect is better. But then I'm sure, like to do a fast forward thing on the little, on the movie, like I'm sure they found out that they were taking out too much and these deficits were just too bad, and then therefore, you had to be really calculated on how much you were taking out, and you don't want to overtake out. Then you have cancers that are just notorious for not being nice and pretty and enveloped and nice, to resect. And one of those is the scariest one, that's a stage 4, even if it's a speck, it doesn't matter if it didn't go anywhere, it's still stage 4 immediately. And that's glioblastoma multiform, GBM. terrifying. Everyone's heard it because of press and everything. And that's because it's not pretty or envelope, but it just injects. I mean, it's just literally, if you could think about it, it's just like these little, how an ink like goes and then it's kind of like thicker at first and then continues to get thinner. That's just how it happens in any direction. So you don't want to resect all of that liberally like you would for a lumpectomy. A lumpectomy,
Right.
you take out the cancer and you're like, dude, I'm going to take out as much as I need to around it to have good tissue, but that's not something that you're given in the brain. And so what we started to do when with the resection, because it's still best for something like GBM, is to say, well, can we at least, like, without taking it out, just kind of radiate everywhere that it was and we know it's probably extending into, and that's called usually, if it's curative, adjuvant radiation for some tumor types. But basically that means we're going to deliver because we took out the bulk of it, but we know stuff is left behind, right? And if I'm, not mistaken, that usually looks like 30 days or so about just getting in there every single day to do radiation to that quote unquote bed, because you also want to kill the stuff that's been left behind.
Glioblastomas really have two problems. Number one is that they are infiltrative tumors, just like you said, so that even if you can physically remove all the cells that you can see, there are always cells left behind. They are infiltrative into the normal brain. So there is no way you can surgically remove all of these tumors. Okay. The other part is that in general, we typically don't try to get margins in the brain, not like you do in the breast or the lung or whatever it may be, because you run the risk of getting into those eloquent areas of the brain and causing a deficit. Okay, so we have to be very careful about how much we remove. Obviously, there is a correlation between how much you can remove and how well patients do, how long it takes until the tumors recur. So but there's a balance between those. Okay, and a lot of it is a balance between surgical resection and functional preservation. But you're right, with a glioblastoma, tumor cells are left behind, and if left to their own devices, these tumors will grow back. Okay, and so we always supplement glioblastoma with adjuvant chemotherapy and radiation. And so you're right, typically anywhere from 3 to 4 weeks after surgery, they receive what we call a full dose of radiation, which is typically 60 gray over the period of 6 weeks. So it's typically once a day, 5 days a week for 6 weeks. And
you said 4 to 6 weeks after the resection, or 3 to 4 weeks?
That's right. So it depends on how well the patient's doing, but in general, on average, patients start radiation and chemotherapy about 4 weeks after surgery.
Right, and that's the same thing with solid tumors in the body. But one could understand why that's unfortunate, because during that 3 or 4 weeks of time, you have cells that are left behind. All the data shows that they continue to progress, but they're going untreated. They weren't resected, and they can't be radiated. And systemic therapy is usually started with radiation. So it would be ideal, and which is why I'm really excited to have you, if you could start that process sooner and really before it just continues to replicate, because we know these things replicate fast, they grow fast.
That's right.
But before we get to that, that's GBM. And what about these meningiomas and secondary tumors? I mean, it's not common you do radiation for meningiomas. You would, especially if you can't resect. But if you were able to maximally resect a meningioma or a lung cancer that went there, or a colon cancer, which usually now we use what's called SBRT or stereotactic radiation, just to kind of quote unquote zap it. In those circumstances, you usually, I guess it depends on the solid tumor, but you resect and the radiation's plus minus, correct?
So for meningiomas, if it's benign, we typically don't radiate. For some of the more malignant meningiomas, we do supplement with radiation because we know those will likely come back. For the metastases, whether it's metastases from a lung cancer, breast, colon, it's the same process as a glioblastoma. We know that cells left behind will continue to grow. And so we always supplement those tumors with radiation as well. So yes, we use stereotactic radiosurgery, and it's to deliver a small amount of radiation to that cavity to kill those same cells.
And by that, do you mean GammaKnife?
So there are multiple kinds. So GammaKnife, there's CyberKnife, there's linear accelerator. There are multiple kinds of ways you can deliver stereotactic radiosurgery, but it's all ultimately the same end goal: to deliver a very focused, accurate dose of radiation to the brain with sparing the normal tissue.
So I still remember when I was a fellow, or maybe a third resident, when I said, "What is GammaKnife?" or these these CyberKnife things that you were talking about? It's radiation. It's not an actual knife that's a scalpel that's going into the brain. And I'm like,
that's right.
How is it not radiation? How is the neurosurgery involved? Can you, in 90 seconds, for everybody, because I think it's confusing a lot of people, explain why is a neurosurgeon involved in GammaKnife? Why is a radiation doctor involved in GammaKnife? and some of these other therapies? Like, which one is it? Whose court is the ball in?
So we really do these cases together, and it's really important because, especially as a surgeon who's physically been in that person's brain, we really know the anatomy well, and we can say, listen, you don't need to worry about radiating that point. We really want you to radiate this area. So we really help to discover, what the margins are, and really sort of, help the radiation oncologist figure out what's important to radiate and what's not. Okay. The radiation oncologist is, they are instrumental in helping us figure out what is an appropriate dose of radiation to give and how to design a plan that is not going to hurt vital other tissues or nerves, eyes, the pituitary gland, and things like that. So it's really important that you work together to really deliver a safe and effective plan.
So the radiation is happening the same way as it would in the body, but in this circumstance, it has to do with like really what they call confirmation and mapping and all that stuff. It takes both to say this is the way you effectively do it in this insanely intimate area, if I haven't said that enough times already.
Right. That's right. Yep.
Now to the concept of those circumstances where you want radiation for those residual cells left behind, because it's just not worth cutting out a whole nother even 1 or 2 millimeters all the way around. It's just not worth it because of the deficits that you're going to have, but they're there. 3 to 4 weeks. I had Dr. Siddhartha Mukherjee, Pulitzer Prize winner of Emperor of All Maladies, the author, on last week, and he made this very important concept that I don't think people think about enough. And he said, you have to remember, Sanjay, whatever disease you have, if it's like 3 sites, 4 sites, whatever the burden is, there is a replication index day to day and week to week, month to month, that basically spits out all these variants, kind of like COVID, but all these variations of mutations that could later down the road be that stop responding to therapy, when really it's that this new thing had come out there and doesn't show itself for 10, 12 months, and everything else has died away. And that is what you want to reduce as quickly as possible. And that really hit home with me because there's so many circumstances where even to get the genomic sequencing or the biopsy and stuff, people don't like me because I'm always like, we need to get this now, and I'm trying to rush roll everything. But that's because you want to treat things the soonest, because you don't want that basically that variability factor to go any longer than you have to.
Sure.
Which, if I understand correctly, that's one of the reasons this really cool novel tool, which is what we talk about in Target Cancer Podcast, about what are the newer things that make theoretical sense but also clinical sense, is to be able to put radiation, start that delivery of radiation right after surgery.
Right.
And I couldn't believe it when I read it. It's called GammaTile, and these little Lego-looking blocks that have these little rods that deliver the same radiation, novel science radiation stuff that you can somehow pack into that cavity, just like the area that you're targeting with radiotherapy. I would say, and I haven't read any of the academic stuff, but it's almost more accurate because at the end of the day, unfortunately, over that 4 to 6 weeks when you're going to that machine, it's all conformed and there's variability with moving and stuff. This is actually placed into that cavity on which you resected and hoping to deliver that radiation in 360 degrees conformationally all around, right where it was resected, and can begin right after the resection?
That's right. So GammaTile is an amazing technology. It is basically a form of brachytherapy, which means implantable radiation. And so over the course of years, there have been many different kinds of radiation that some have worked, some haven't. But ultimately, we don't have a great thing for the brain right now from a brachytherapy standpoint. Brachytherapy is used all the time for prostate cancer. But until recently, this came along for us. And basically, it's a type of cesium radiation. They are in each tile, there are 4 cesium-131 seeds embedded in these tiles, which are about the size of a postage stamp. And what happens is after somebody like I goes in and removes a tumor, right, no matter how big, no matter what shape, as long as we feel like we can remove nearly all of it or all of it, we can then lay these different tiles within the resection cavity themselves. And what the nice thing is that you talk about conformality, and so we don't have to create some crazy physics-based plan from an external beam radiation, because we know I can lay these tiles in at the time of surgery and they are going to fit exactly as I want them to.
Like a glove.
Like a glove. And even as soon as I put these in, the radiation starts working. So all those small cells that we know are left in there, whether it's a glioblastoma, whether it's a metastasis, no matter what it is, the radiation starts working immediately, and you do not have to wait that 4 weeks that we typically would to give external beam radiation. And so we don't even give the cells a chance to grow back initially. You're
During
already
that
starting.
free time, yeah. So that's absolutely wild, is that you can actually put it in right immediately after. And like we said, you want to theoretically, it's just theory for now, cytoreduce, meaning knock out the cells as fast as you can, as early as you can, to keep them from getting these errors. Just like, again, like we've been through the whole Greek alphabet in COVID. That's because the longer something can persist, the more variants it's going to have, and somehow that M protein that all the vaccines are attacking is all of a sudden that M spike, it just looks different, and all of a sudden the things that your lymphocytes are primed and ready to see don't recognize it, and that's because you've had a billion and trillion gazillion different like replications to basically have opportunity for that protein to change. But the big thing for any academician, and which is what I have to be careful about on social media and podcasts and everything else, is it data proven to be equivalent to that? When you said external beam, just so people know, that means you go into the thing and basically I mean, it's wicked technology, but is able to basically conform in a whole 360 degrees that area and radiate to it every day for 4 to 6 weeks. Is it similar? Is there data for it? Is it pending?
Yeah, so this was FDA approved. So initially there was a large clinical trial out of Arizona from 2013 to 2018, which looked at basically any recurrence tumor, right? So they took glioblastoma, meningioma, metastases, and so all these tumors which had initially been treated and then recurred, which were surgically, amenable to treatment, went back in, removed the tumor, placed the GammaTile, and they ultimately looked at how did these patients do over time. Did they looked at local recurrence, overall survival, all these things, complication rate. And what they found is, and what ultimately led to FDA approval, was that patients in all these different disease classes did better. The complications rates were low. And so patients were living longer and were having further time to ultimate progression. And so initially this was approved for any recurrent malignant tumor. And then about a year later, they were actually approved for any newly diagnosed or presumed high-grade or malignancy tumor. So now not only do we use these in patients who have known recurrences of metastases, gliomas, meningiomas, but now we can actually use these in the upfront treatment, which is really changing the way we treat these tumors. And so, one of the best things that they are doing now is there are 2 clinical trials that are in the works to sort of see, is this better than the current standard of care? And for metastases, patients are having these resected with GammaTile implantation, and we're looking at and actively comparing, is this better than the standard of care with, external beam radiation, GammaKnife, SRS? And really the goal is this non-inferior, which means that is it basically equivalent with respect to outcome, but are the rates of leptomeningeal disease and radiation necrosis improved? Because we know those can be big trouble with large doses of radiation for metastatic disease. From a glioblastoma standpoint, the current gold standard of care, which has been for decades, is resection, followed by what we call the STOOP protocol, chemoradiation therapy, which is that 6 weeks of radiation every day, and temozolomide. Okay, that has been the dogma for decades, and nothing has really changed that. And what we are seeing now, and there's currently a trial which we've just started, where we are doing upfront treatment with resection plus GammaTile, and then letting that work for several weeks, 4 weeks, and then afterwards supplementing with a lower dose of radiation and chemotherapy. And the hope is that could this move the needle in these patients with these horrible tumors, which hasn't been changed at all for decades? And so the hope is that by doing this implantation up front, these patients are actually going to have a much better quality of life, live longer, and have a much longer progression-free survival for these tumors.
That's incredible.
We've actually seen some patients who have done extremely well with some very difficult tumors, which have either come back, and we've had a treat for the 3rd, 4th, 5th time we've used GammaTile, and they've done well. And then now we've got several patients that we've just started doing these on the upfront glioblastomas. And miraculously, these patients have done well without needing radiation. So it's really going to be interesting once the trial gets going to see how these patients do long term. So we're very hopeful about it. One of the best things about this is that there's sort of a built-in compliance. And so for patients who have transportation issues or potentially socioeconomic issues, they can't make it back and forth to radiation for whatever reason, you can put this in and it's sort of like a one-stop shop. So they get surgery, plus they get the radiation, and they're done.
We're having to take all of these measures to really protect the thing that we can't seem to fix or restore. What are some of the things a step ahead, where it's like in this ideal world, where we can say, aha, we can actually regenerate this or support this, right? Everyone talks all the time about stem cells. And I've read data on stem cells helping autism. It's one thing to use stem cells in, joints and stuff. That all makes sense. Even PRP, platelet therapy, they're granulated. All that stuff makes sense. But really to reinstigate or reperpetuate this cascade that just is designed to just start when you're born, and that's why you don't have kids that are 3 and 4 necessarily in wheelchairs, because you still continue to have that growth and then it just halts, right? As I understand it, it's like 5 years old or so, then all of a sudden it's just frozen. What are we doing? Is there anything promising that we can hope for and look forward to say, oh, even if we cut off a little bit, we'll just squeeze this stuff in there and all of a sudden this stuff will regenerate? Tell me you have the answer.
I wish. I mean, I would say that there's a lot of work going on with stem cells for brain tumor and different cancers. I don't think any of it's ready for prime time yet. I'm hopeful that within the next years or decades, maybe we will, but I don't think right now we're there. I will say, though, that the brain, despite all the eloquence that we have, has a tremendous ability to be plastic and sort of reorganize. And so we see some patients who you can remove a tumor from, the temporal lobe, they have a speech deficit, and then over time that can sort of reshift and change, and patients can actually, have the ability to speak again. Now, again, that's not in everybody, and that's not in everything, but it is amazing how the brain can reorganize itself and have some redundant systems and pathways where people can actually improve after a deficit, whether it be
fail stops. So it's not that it's growing back, but it's just has this kind of like thing where you got to shake the dust off of, change the, it's kind of like
reorganization.
Like an engine to charge on, just say, and then it'll wake up and basically take over what has been removed. That's interesting. So, as a tangent to that, the thing I always say, I'm an inpatient, I hope I'm not incorrect, because this is what I learned in residency, was the whole concept of rehab, re-stimulation after a stroke or anything else, surgery. But the thing I stress, and I hope I'm not incorrect, is that doing it as closely as after the injury, as I understand it, is more effective than waiting 4 weeks, just like the same way of doing radiation. Is that true? Do you get this kind of wakening and dusting of the stuff and to really aggressively hit it as early as you can?
Anybody who has any sort of deficit, whether it be speech or swallowing, speaking, any of these things, strength, balance, all these things, we really advocate for rehab, because you're absolutely right. The soonest you can do it, the better people can improve. So even if it's a simple thing, occupational therapy, physical therapy, speech therapy, all those things are tremendously important.
Dr. McCracken, you are awesome. I can't believe I got to talk to a cool neurosurgeon. This has been awesome. But we appreciate you. It sounds like everyone can find you anywhere in the Atlanta area or otherwise. It's where I got married, with Smyrna, the little outlier from Atlanta. But they can find you at Piedmont. They can find you in Atlanta if anyone's considering, and especially if they're younger. It sounds like, again, this is not medical advice, but it sounds like if you're younger, 30s, 40s, and you have these brain, issues, and especially if you're looking for curative stuff, like the long-term hope and planning should be a part of that treatment decision. And it sounds like GammaTile is a more precise. The data shows that, and potentially less, long-term side effects. And it's being studied as we speak to see if it's at least the same, if not better.
That's right. If you're living with a brain tumor, struggling with it, there's a ton of support out there for you. Certainly, we at Piedmont are always happy to, entertain, helping you or discussing a case with you, or really anybody else out there. So you can, if you're interested in GammaTile, their website's fantastic. You can see all the different centers across the country who are using it, anywhere that's close to you as well. So, Sanjay, I just so appreciate you having me on, and thank you. Thank you.
Of course. And can they find you on social media, or is it just mostly Piedmont?
Yeah, I'm on Instagram, Facebook, and Twitter.
All right. Well, Jay, thank you so much. This has been awesome.
Thank you.